don't work in patients who don't take them.
A sub-analysis of the SPRINT trial, results are exactly the same, so almost the same point estimate, 26% relative risk reduction of major cardiovascular events, which is similar to the SPRINT trial.
It's better to consider either RAS blocker with a calcium channel blocker or diuretic.
So here's a systematic review of RCTs, testing, assessing the effect of different mobile apps to support medication adherence.
This section of the Dubrovnik Forum on Cardiometabolic and Venous Diseases focuses on hypertension. Several experts will join us to discuss key aspects of hypertension, including the guideline recommendations for initiating treatment with single-pill combinations. The first expert is Konstantinos Tsioufis.
This is a nice figure summarizing the therapeutic algorithm of hypertensive patients. I would like to ask for your attention at 2 points. First, the guidelines recommend to start with dual combination therapy in most patients. And second point, prefer single-pill combinations at any step. This is my topic today, to discuss the single-pill combination for the treatment of hypertension. And what was the rationale for these recommendations for dual combination for most patients at the initial visit, and particularly for single-pill combination? The first reason coming from the epidemiology. We all are familiar with the high rate of uncontrolled hypertension worldwide. You see here, in different geographic areas, the rate of treated but uncontrolled hypertension remains high. So we have something to do in order to improve the blood pressure controls. And we know that poor medication adherence contributes to these high rates of uncontrolled hypertension. Drugs don't work in patients who don't take them. This statement highlights also the important role of the physicians, our important role in order to build a good relationship with the patient and to explain the benefits of antihypertensive medication, the risk associated by remaining the blood pressure at a high level in order to improve the medication adherence. And we have plenty of data showing that the adherence to medication, and this not only to hypertension, but also to all chronic conditions, are very high. This is true in the setting of clinical randomized trials, but also in the real world.
Professor Tsioufis, while this is the position of the guidelines, what is the stance of other authorities, such as European institutions?
For this reason, also the European Union, there was an initiative how to take into account the improvement of medication adherence, and Servier contributed to this initiative with very good results. Last November, take place this event.
Many thanks for that insight. It was not widely known that pharmaceutical industries were also involved in such important documents. Now, it is a pleasure to introduce Professor Otavio Berwanger, Executive Director of the George Institute for Global Health and Chair of Clinical Trials in London. Professor Berwanger, you consistently provide valuable ideas for improving guidelines. Could you share the latest developments at the George Institute?
While I do agree with most of the guidelines recommendations, once again, they're great documents, I think there's still room for discussion in terms of the elderly patients and in terms of patients with diabetes and stroke. And I would like to present some of the reasons for that, and also some of the ongoing trials that can challenge a bit these recommendations, hopefully, depending on the results. I think the first concept is that although we divide patients into hypertensive and non-hypertensive, actually is not quite like that. If we look at the observational data, both for systolic and diastolic blood pressure, and here I'm presenting mortality due to ischemic heart disease, but if you change the graph to hospitalization for heart failure, incidence of chronic kidney disease, dementia, or stroke, it will be exactly the same. the risk is log linear. So the lower you go, both for systolic and diastolic blood pressure, the better, the less risk of an event. And obviously, if you can go as low as 110, 100 or 70 of diastolic blood pressure, the lower you go, the lower the risk. This comes from 1 million patients, the 61 prospective cohort studies. It's an individual patient data meta-analysis. And interestingly enough, when you look at the randomized trial evidence, exactly what is predicted by the observational studies happens. So if you look at the SPRINT trial, exactly what was predicted according to a gradient of 13 millimeters of mercury happened, 25% less risk of major cardiovascular event, 27% less all-cause mortality, and 43% less cardiovascular mortality, and several systematic reviews have replicated that. And then you ask, well, what about elderly patients? Because there are some concerns in elderly patients, this might be a bit challenging. But I think there are two concepts here that are important. Number one is, it is a methodological concept, but it has practical implications to inform decisions. Is the difference between relative risk and absolute risk. If you look at younger patients, obviously the relative risk is higher in the younger patients because you compare someone with hypertension with someone without hypertension. A younger patient without hypertension, the risk is very low. If you add hypertension and other risk factors, obviously the risk will be higher. So if you do a risk ratio, obviously in the young patients, the relative risk will be much higher. And obviously even elderly patients without hypertension, they are at high risk of developing cardiovascular events. So the relative risk in elderly patients is quite low in red. But when you go to the absolute risk, the elderly patients are the ones who are at very high risk of developing events. So hypertension is not a natural consequence of age. It's not, oh, elderly patients, the blood pressure will be higher anyway, there will be high risk anyway. This is wrong. I mean, hypertension is still the #1 killer in the world and is something to be avoided. It's not a natural consequence of age. This is important. And interestingly enough, this is also coming from meta-analysis of observational studies. When you do randomized trials in elderly patients, including the STEP trial, and even when you look at a sub-analysis of the SPRINT trial, results are exactly the same. So almost the same point estimate, 26% relative risk reduction of major cardiovascular events, which is similar to the SPRINT trial. So that's something to consider. I'll tend to try to go a bit lower in the elderly patients, and I won't start treatment, and I won't withhold treatment if their blood pressure is lower than 160, and I'll try to reach lower targets in elderly patients. So that's something that I'll do different from the guidelines. It's controversial, open for discussion. The other thing is that in the two populations, both patients with diabetes and stroke, we have evidence for combination of, especially thiazide-like diuretics like indapamide combined with an ACE inhibitor seems to be a powerful combination for patients with diabetes and patients with stroke. And although we don't have evidence, we're trying to generate further information on whether we should go lower in these patients. And we are currently conducting 2 trials. It's the Optimal program. It's a 14,000 patient randomized trial program, including 2 twin trials. One is the Optimal Diabetes trial, which is fully recruited. We have around 9,500 patients. These are patients with diabetes and high cardiovascular risk, same primary outcome as SPRINT. And we are comparing a lower target, putting these patients in less than 120. And I can tell you in the trial, they're really going to less than 120, and that's office blood pressure, versus a standard treatment goal of less than 140, and that's because we have several elderly patients in the trial. So we're trying to challenge a bit these recommendations, and obviously we need to wait for the results. Hopefully they will be available soon. And we have a twin trial in patients with previous stroke or TIA, about 4,400 patients, also randomized to intensive blood pressure target of less than systolic blood pressure less than 120, less than 140, so similar to SPRINT, and also looking at the same primary endpoint as SPRINT. Of course, the trials are ongoing. What I can tell you, and we have several elderly patients in both trials, what I can tell you, and this is not confidential, is that for both trials, we had 2 data monitoring committee meetings. And so far, they told us, keep going, and no safety concerns seem at this point, so no need to change the protocol. So it seems to be safe to do that, and seems to be consistent with previous evidence, but obviously we're blinded to the results, just that the MC knows that, and knows them, and we need to wait for the results. The other thing we recently completed, and results will be available, actually the results are available, but they are embargoed due to journal policies because they're under consideration. But we at the George Institute, we have a group of people doing meta-analysis and systematic reviews, and we recently completed what we call the DREAM project, which includes 500 double-blind placebo-controlled trials of hypertension in over 100,000 patients. And what we came up with is informed by the trial evidence. We have an online tool that you'll be able to input your patient characteristics, their baseline blood pressure, and you can predict exactly what will happen with all types of combinations between all types of classes. So hopefully this is something that will be available soon and could guide some decisions. And just a final point in terms of how fast should we go to control patients, which is, I think, is also an interesting area for research. Number one, we need to remember, and that's also based on trial data, based on that systematic review that I mentioned. This is, I can tell you, around 80% of the pharmacological effect is achieved in 2 weeks. So if your patients are taking their pills, what you see in 2 weeks is what's going to happen. So there's no reason to wait longer to change the medication. So if you wait longer, that's therapeutic inertia. And the other thing, which is also based on previous studies, especially observational studies and some registries, of course, blood pressure levels, they're not fixed, they fluctuate. So there is a standard deviation of 8 to 10 millimeters of mercury between visits and between patients. So it means that if you want to target less than 130 over 80, you need to target a bit less. Maybe you need to target 125 or something like that, or 120, because then blood pressure fluctuates and you achieve less than 130. So if you target too close to the goal, there's a high chance you'll not be able to reach the goal. So that's another thing that I think a faster up escalation may be needed, and you need to be slightly more aggressive if you want to reach targets. And I think the other concept, just to finalize 2 other concepts, and that's also based on some research that the George Institute is conducting. I think the concept, and I entirely agree with the guidelines that starting with dual therapy, using single combination pills, it's for the moment the way to go. I completely agree with that. Although I would say that if you want to be slightly more aggressive, lots of patients will need 3 classes. But anyway, I think the guidelines are absolutely correct. But we are generating further evidence that using triple or quadruple combinations, using low doses and ultra-low doses as a first step can be interesting and can actually reduce the risk of side effects and can put more patients in control rapidly. So, and these are some initial studies, quite interesting studies. I do agree with the guidelines that we need evidence in broader populations. And just to finalize, that's exactly something we're trying to do now at the George, using ultra-low dose and low-dose combinations as first step. And you can see it is a mix between using triple pills, ultra-low dose and single dose, and also rapid escalation therapy. So we start with a triple pill, ultra-low dose, or standard or low dose, depending on your baseline blood pressure. You try to see the patients in 2 weeks, because that's when we expect that most effects will happen. If he or she is not controlled, then you up escalate, force it. And then you see them again in 2 weeks and up escalate. We have some pilot studies suggesting that you can definitely achieve, as the guidelines suggest, over 90% or close to 90% control quite rapidly. And then you say, well, but it's a bit challenging in terms of the system to bring patients in 2 weeks. Yeah, but you gain time later on avoiding other unnecessary visits.
Thank you. We now have the pleasure of welcoming Professor Athanasios Manolis, Director, Cardiology Department, Metropolitan Hospital in Athens, who will share his insights on the best combination therapy to use.
You are very familiar with this slide that you have seen from the previous speakers, that unless you are a low-risk person, or you have a high normal blood pressure, or a frail elderly person, then in all other cases, you have to start with a dual combination therapy in most patients. And this combination will be a RAS blocker with a calcium channel blocker or a diuretic. So I will try to be more practical today. So, when to select a RAS blocker with a calcium channel blocker or a RAS blocker with a diuretic? If you have a high-risk person, then the ideal will be to combine a RAS blocker with a calcium channel blocker, unless you have an acceptable edema, hypervolemia, or advanced nephropathy. On the other hand, if you have a low-risk person, it's better to consider either RAS blocker with a calcium channel blocker or diuretic. However, if you have metabolic abnormalities or hypokalemia-prone person, then the ideal will be to combine a RAS blocker with a calcium channel blocker. Next step will be which calcium channel blocker, because there are many. You have seen earlier the data from the ASCO trial, where they compare peridopril plus amlodipine versus atenolol with hydrochlorothiazide, and they have seen significant reduction of all cardiovascular events in those treated with peridopril amlodipine, but also in the VALUE trial, they compare once again valsartan with amlodipine. So I think at this moment, amlodipine is the most popular calcium channel blocker in daily practice. And as you can see from this systematic review, it seems that the combination of peridopril with amlodipine, like a fixed dose combination, reduce significantly the blood pressure in all the area of cardiovascular continuum. Now, we are talking about RAS blocker, but ACE inhibitors or ARBs. Are there differences between ACE inhibitors and ARBs? As you can see from this paper, looking to the total mortality in hypertensive patients, you can see that both drugs, as you can see, are equally effective in reducing mortality. However, if you will see the subgroup analysis, you can see that all beneficial effect is from ACE inhibitors, not ARBs. That's why in most guidelines, in many guidelines, they propose to start with ACE inhibitors and in those not tolerated ACE inhibitors to proceed with the RAS blocker. And this is another review comparing RAS blocker with ACE inhibitors. As you can see, by using ARBs, we have a reduction of cardiovascular events, mostly non-significant. However, in comparison with, as you can see, ACE inhibitors, there is a significant reduction of cardiovascular events. That means there is a clear superiority of ACE inhibitors versus ARBs. So the next step is, are all ACE inhibitors the same? For sure, there is no head-to-head comparison. There is only one in patients with acute myocardial infarction comparing zofenopril with ramipril, and they found that zofenopril was superior than ramipril. On the other hand, for the same population, we have two similar trials, the PEACE trial and the Europa trial. In the PEACE trial with tardolapril, they have seen an improvement in cardiovascular events at the top of standard therapy. In the Europa trial, they have seen that peridopril was much more effective than placebo in reducing cardiovascular events. That means there are differences in the field of ACE inhibitors, and we have data that peridopril, at least in patients with coronary artery disease, it's much more effective than other ARBs. Then we propose to combine RAS blocker with a diuretic. Which type of diuretic? Thiazide type or thiazide-like type diuretic, such as indapamide and chlorothalidone? As you can see from this meta-analysis, it seems that by using thiazide type-like diuretics, there was a decrease, 20% risk reduction of cardiovascular events and 21% additional risk reduction of heart failure. That means by using thiazide-type-like diuretics is the ideal one. A lot of discussion in the past if we can use in the treatment of blood pressure beta blockers. Can we use beta blockers in daily practice as monotherapy or combination therapy? As you can see on the right side of this figure from the guidelines, we propose in the guidelines that can be used as monotherapy or a 10-step of combination therapy, because we have seen from randomized controlled trials that all classes of antihypertensive drugs are equally effective and all of them received the same indication 1A. The question is, can we combine beta blockers with other classes of drugs? Here, there is a paper that we published a few years ago, large number of participants, real-world data from the Benefit Korea trial, and as you can see, by adding a beta blocker on the top of a RAS blocker or a calcium channel blocker, the combination is effective. And here, we have some data by adding bisoprolol on the top of uncontrolled hypertensive patients with 5 milligram amlodipine. There was a significant reduction of blood pressure. That means always there is a position of beta blockers in the field of hypertension, and we can combine them with either RAS blocker or a calcium channel blocker in daily practice. You have seen also from all the previous speakers the importance of adherence. As you can see here, no matter if you have dyslipidemia, if you have high blood pressure, diabetes, by the end of the year, less than 50% of them will continue to receive their drug treatment. And as you have seen from some studies from Italy, 1/3 of our hypertensive patients have only one prescription. Then they don't go back again. So why we are proposing the combination treatment as first step? Because we have seen that we will improve the control of blood pressure. Also, we'll increase the speed to achieve the blood pressure control, because in the value trial, there was no matter if you use amlodipine or valsartan. The earlier the control of blood pressure, the lower the cardiovascular risk. Also, we'll overcome the therapeutic inertia, and also we will decrease the variability in the blood pressure response. And as you can see here, by using fixed dose combination, we can improve the adherence in daily practice. We have data that normalization rate will be higher in those using fixed dose combination.
Thank you, Professor Manolis. Let's turn once again to Professor Berwanger to discuss whether digitalization could enhance patient compliance.
There are tons of apps being launched every day. There's a lot of hype, but I think what we need to analyze and critically appraise is if we have enough randomized evidence from high-quality randomized trials. So here's a systematic review of RCTs, testing, assessing the effect of different mobile apps to support medication adherence. Most trials were trials conducted in patients with cardiometabolic disease. And in general, when we lump together the RCTs, we find that mobile device apps in general tend to increase adherence by twofold, so they tend to work. There's no trial assessing the effects of mobile device apps on major cardiovascular events yet, but in terms of adherence, yes, definitely it's possible to increase adherence. Adherence being measured by different methods by each of the trials. And in patients with hypertension, I think another question is whether by improving adherence, you could also improve blood pressure control. You could decrease levels of, for example, systolic blood pressure. And there's been around 4 or 5 small trials testing that. And this is a systematic review and meta-analysis of RCTs that assess the effects of smartphone app-based applications on blood pressure control. And as you can see in general, systolic blood pressure, when you lump together the effects of different trials, they tend to decrease by 2.3 millimeters of mercury. Some might say, well, that's a bit small. Well, that means around 10% less risk of stroke. So it can, for something that's easy to use and probably non-expensive. But some characteristics of apps are desirable. As in any implementation science study, you need things that are proactive, that are active and that engage with the user. And a particular way of doing that is through gamification. So gamification deals with different domains and different components, but it has to do with, I would say, a positive way of creating competition between users and also rely on rewards and feedback to users. So gamification is probably one of the most promising ways of developing digital applications because you can create true engagement and you can also create retention. And we're starting more and more to see gamified apps and randomized trials testing them. Probably some of you were at the American College of Cardiology scientific sessions this year, and one of the late breakers published simultaneously in circulation was the Be Active trial, testing a gamified app together with financial incentives to improve physical activity among patients with heart failure. And you can see that actually they reached the trial met its primary endpoint. So over a 12-month follow-up period, there was substantially increased physical activity compared to the control group in users of this app together with financial incentives. And just to finalize, I also would like to give a concrete example. That's something that we are developing in partnership with Servier and a company called Elfi. So Elfi is one of a new potential application that uses a gamified approach in order to improve adherence. Initially, it has a focus on patients with cardiometabolic diseases, but of course it goes beyond that. And it has some interesting principles, and that's why from a scientific perspective, I got attracted to Elfi. Number one, it has a component of self-monitoring. So together with gamification, self-monitoring is important. So you can create your own profile and monitor the control of different risk factors that you have. Number two, you receive very clear and proactive audit and feedback reports. And we also know from implementation science that together with reminders, audit and feedback is a very powerful way of changing behavior. So you can track your vitals in your medication adherence. And then, of course, you have the gamify component, which is about reward and incentives. And it also creates competition between you and your family or you and your other peers. Together with that, so together with the gamify component, the self-monitoring component, and the audit and feedback component, there are some other interesting features. Number one is they have some embedded AI technology, so you have digital avatars. So you can create an avatar that can speak virtually any language and could look anything that you like. And the digital coach is a very powerful way and funny way of creating reminders. So instead of those non-sexy text messages, you can have an avatar really talking to you and incentivizing you to take your pills and to control your risk factors. Obviously, the audit and feedback component is very easy to see. So you have a dashboard that you can use for self-monitoring. And similarly, to improve adherence, you have a digital pill box, which is linked to WHO drugs. So you have virtually any drug can be assessed using the digital pill box tool. So that's for patients and for users, but also for those, for healthcare providers, including doctors, nurses, community healthcare workers, it doesn't matter. You also have now a component called Elfi Care, which also use a gamified approach to reward frontline health agencies to educate patients on risk factors. So something that can be used, for example, in low-income countries, something that, for example, community healthcare workers in low-income countries could potentially use. And also, for example, for doctors, you can have something like a mini EMR of your cardiometabolic risk factors. So in each visit, your doctor can access that and also provide you feedback. So quite an interesting application for implementation science from a healthcare perspective. And finally, something I'm involved with them at the moment, being a trialist myself, it's an application called ELFI research that can be used to conduct large-scale and efficient real-world evidence studies. And we're now developing a new component for decentralized, large-scale pragmatic trials, so we can also, in the future, be able to conduct a randomized trial just using their application. And it's really catching over. You see, and I asked Ophir, which is the CEO of ELFI, to send me this data 2 days ago, and 48 hours ago, they have close to 250,000 users in ELFI. So I think very rapidly they will approach like 1 million users, et cetera. Interesting enough, most of their patients are patients with cardiometabolic conditions, and you can see around 30% of them, of the 250,000, are patients with what you will call a patient with multimorbidity, with 3 or more chronic conditions. And we're now conducting more specific analysis using their data, but interestingly enough, there are some signals. Of course, this will need to be approached with more proper and detailed statistical methodology, but just looking at their data, and obviously there is some noise here, but you can see that adherence tend to improve over time for ELFI users, and their retention rates are quite interesting. And here's another thing that, once again, we need to analyze that properly, but at least there is a signal here. It's the effect on risk factor control. So they have several of their users are patients with hypertension, and you can see that over time. And obviously you have probably some noise here and regression to the mean and other things that you need to adjust for when you do proper analysis. But even though there is a clear signal that for those who are able to retain the app and improve adherence, there is a quite interesting effect in both systolic and diastolic blood pressure over time. So there's a lot of promise. Once again, in terms of generating real-world evidence, we need to analyze data properly, but it's definitely promising, definitely, even I think after adjust for regression to the mean or other factors, there's something here. And interestingly enough, they are also interested in conducting research. So they're currently conducting a randomized trial in 2 countries, Brazil and Vietnam, close to 900 patients. And these are patients with adult patients with hypertension, using at least 1 blood pressure lowering drug, uncontrolled patients, and they're being randomized in a very pragmatic trial to ELFI or to usual care. The trial is powered to assess office systolic blood pressure as the primary outcome, but they have other secondary outcomes like adherence and a lot of other parameters of gamified application. So hopefully results, I think the trial is just starting, and results should be available in the near future. I think that's my last slide, and I'll give you back 3.5 minutes. Thank you very much.
We hope you enjoy the highlights. You may now post your questions in the comment box below. We will provide our feedbacks, and the P2P channel secretariat will post them on our behalf.